Very often I'll wonder which came first, the mental illness or the substance use, or the substance use and then the mental illness. And that happens because very frequently you'll see them co-occurring. So there is a list of substances that can be abused, and they're listed here. And like when I ask patient about their coffee use, they'll be like, coffee? Why? Why is that an issue? Because coffee, as we know, is a stimulant and can cause what kind of feelings?
Anxiety.
Yes, anxious feelings. So this is when patient uses, well, they have a maladaptive use of mood altering substances, or it alters their behaviors. It could be an occasional abuse. It could be intoxication related to prolonged abuse and or use and or abuse. It results in psychological and physiological dependence. It's chronic, they often relapse, and frequently part of a dual diagnosis. And this is what I mean by like substance use and mental illness. So usually you'll see them go hand in hand. So what are some key indicators that we need to have some interventions for patients? This is when the patient has adverse consequences in areas of mental or physical health. So like, what are some adverse consequences you could see as a result of smoking or using drugs? They could have developed lung disease. They could have lost their jobs. They could have kidney failure, liver failure, developed ascites, and they can tell you because I drink, but they're not stopping. They could have behavioral evidence that their use is pathologic. They're drinking every day, every night. They have impaired control. So this is the patient who tells you, I try to stop, I try to cut down, but I'm having a hard time doing so. This is the patient who has social impairment. They tell you, I don't go out, I just stay home and drink. They're having a hard time engaging with others socially because they're making time to drink. Risky use. This is the patient that tells you, I drink. After I leave work, I go to the bar and I drink before I drive home. That's kind of dangerous, don't you think? So there's usually a list of criteria that these patients have to meet in order to develop this diagnosis. Some other key indicators: binge drinking, like which a lot of college age young adults engage in, is now on the spectrum of alcohol use disorders. This patient often has behavioral or psychological changes associated with the intoxication. It causes significant distress, the use in social, occupational, someone mentioned loss of job, loss of loved one, loss of relationships because of this substance use. Or I can't stay with him, or I can't stay with her because they drink too much, or when he drinks, she gets really angry and irritable, so other people will tend to stay away from you because of that. So 1 in 3 of all hospital admissions are related to alcohol use disorders. It's very prevalent. 1 in 2 motor vehicle accidents are alcohol related. There are usually multifactorial causes for someone to engage in alcohol, or not alcohol, but substance use and or abuse. It could be genetic. Research has shown that there's a familial gene, there's bloodlines, there's something that ties genes into substance use. It could be some offset in their neurobiological or neurochemicals. Like for schizophrenics, it is said that they have some alpha nicotinic receptors, which makes them more prone to smoking. Most schizophrenic patients smoke. So it's some alterations in their neurobiological, neurochemical system, either or, that causes this affinity for smoking. It could be psychodynamic or social components that allows these patients to smoke the way they do or drink the way they do. Maybe it's what everybody else is doing. Maybe they grew up in a household where alcohol was commonplace, where everybody was drinking. Substance abusers are 20 times more likely to die by suicide. So, how are some ways we can suspect substance use? I can remember like working in detention. When I worked in detention, and we'll have new intakes, and they will send them down to the nurses. Can you tell us if he was using? Or can you tell us if he's under the influence? So what are some things you'd look for? Reddened, altered mental status, which is like bing bang, definitely.
Pupil sizes?
Yes. Pupil sizes, reddened conjunctiva, slurred speech. So those are things we can see like in a more immediate. Odor, yes. Sometimes you can definitely smell, especially like alcohol and weed emanating out of their pores. You can smell it on them. So those are things we could notice more in the acute setting. What about like in the community? Say you work in an outpatient where someone comes in regularly for appointments and you assess them over time.
Weight loss?
Yes.
Or gain?
Long sleeves in the warm, hot weather. Missing work, missing school, missing social obligations. Irritability, yes. Those marks on their arms, yes. Or legs or wherever it is. Lying, denial. So these are all signs. So while this patient is presenting and everything seems okay, you can look at these more objective signs and realize that something's aloof, something's just not quite adding up here. So substance use is often characterized by use that leads to abuse, and then by default, it turns into dependence. So this patient will have at least 2 signs and symptoms occurring within the last 12 months. So within the last year, at least 2. A failure to meet role obligations. They're missing work. They're not parenting effectively. They are not doing what they're supposed to do in their role. They have recurrent use in physically hazardous situations. They're drinking while driving, like that's hazardous. Or they drink and then drive. They are getting into legal spats, getting into issues all the time. So what is going on? Why is there this change in their behavior? What could be influencing these behaviors? Their use leads to social or interpersonal problems for them. They're taking larger amounts or longer than intended. Like I had one patient last week who I prescribed Klonopin for. She shares with me and she says, well, I upped my Klonopin because, so she has 1 milligram prescribed for twice daily. And she let me know she increased her dose because the 1 milligram wasn't working once a day anymore. So she started taking 2 milligrams 2 times daily. So she has run out of medications and she wants me to write a new script, because not just a new script, but she wants me to write a new script to meet her new usage. So what does that tell you? Like, what red flags is that showing? That there's a possibility of abuse. She now needs a larger, like more amount to meet her needs. There's a possibility of dependence. Often these patients will spend a great deal of time trying to obtain or use these substances. So whether it involves hospital shopping or taking time off work, or I remember I worked with a nurse once, and it was so eye-opening when she shared this with me. It was while I was in NP school. And I was in NP school, and I guess as I was nearing the end, we worked very closely together because her and I used to work second shift, and second shift is pretty quiet, so we get to talking about a lot of personal stuff. We get to know a lot more about each other, and it was just her and I on the shift every evening. And as I got closer to finishing the psych nurse practitioner program, she started telling me more about her, not just her in general, but her psychiatric history, which I had no inclination that she had. And she shared with me that she was a drug addict. My eyes were like I didn't know I worked this close with someone who used drugs or had a drug history. Like, oh wow. So I'm thinking she's doing a really good job covering up and doing what she's supposed to do. And she shared with me that she had told me that she had recently started therapy. And she goes, well, you're going to find out that those patients, I forgot what the name of the therapy group was, are patients who are recovering addicts. I'm like, recovering? Are you currently using? She goes, yes, I relapsed recently. What substance? Heroin and crack. I was like, oh wow, like anybody else hearing this stuff? Like I thought this was like huge. Like I've heard about drugs, hear people use drugs, but never been close to anyone who said they use drugs or I know of them using drugs. So this was like a eye-opener to me. And she's sharing with me that she had lost her last job because of drug use. She said she used to work the 3 to 11 shift or the 4 to 12 shift, whatever shift it was either 11 or 12 that she got off. But she would often leave work. I guess the rule was you couldn't leave the facility, even on your lunch break, you can't leave. But she would often leave work because she had to go get drugs before she got off. I think it was 12 before she got off at midnight, because if she waited until midnight, then it would be too late to get drugs from whoever she bought it from. So she had to leave work to go get it around 9, 10 o'clock at night. So she lost her job. And she said to me, that's not the first job I lost. I lost my job before that too, because I spent more time trying to get the drugs than doing what I needed to do. So I'm just saying, they'll spend a large amount of time trying to get this substance. They will give up or limit important social or occupational activities because of substance use or abuse. They'll have continued use despite having physical or psychological problems. They will have tolerance. And this is what I meant with my parents. Not my parents, my patient who wanted me to start writing 2 milligrams twice a day instead of 1 milligram twice a day. Tolerance. She now needs an increased amount to start getting the same effect. So while the 1 twice a day was working, now she's up to 2 because 1 is not doing anything for me anymore, as she would say. They have dependence. They have continued maladaptive pattern of abuse with significant impact on thoughts, behaviors, and their daily life. They will have withdrawal, which is a physical or physiological change which they will have from not having this substance. This is why when patients are abusing drugs and you find that they're in treatment, they will be on different substances to help them work through the abuse, and over time it gets decreased and more decreased until they're off totally. What is one substance you will find patients on who are in drug rehab?
Suboxone?
Suboxone, methadone, yes.
Mm.
So you'll definitely find patients on those drugs. Where I work, we have a substance use program where the patients are on Suboxone. We don't do methadone where I work, but those are two of the drugs. Buprenorphine, you'll find patients on those drugs while they're in substance recovery. Christina, you wrote one patient had 6 providers writing oxycodone, and that is crazy because there's something called the PMP, the Prescription Monitoring. I forgot what the last P stand for, but it's PMP. And before every script that I write of a narcotic, of a controlled drug, either I go on there myself or ask my assistant to go on there and check. Can you tell me when John Brown last had a refill of Klonopin? Or can you tell me if he's getting oxycodone or fentanyl or anything from anybody else? Because one of the rules for prescribing is, well, for me, I don't prescribe to patients who are taking opiates. You're not going to get a benzo on an opiate. So if you're on opiates, I will not treat your anxiety with a benzo. Or if you're taking a benzo from me, you should have one prescriptive home. Please don't tell me you went to your primary care and she just happened to give you some Xanax, even though you're getting Klonopin from me, because then, like I had one patient who just doesn't, every time I'd see her, she would need more and more and more and more and more. So I ended up prescribing for her more than I would have prescribed for any other patient. I mean, this is the patient who presented very well. She was in school working on her master's, but her anxiety was so much that she just kept requiring more and more and more and more. So till I got to the point where I'm like, I will not increase this any further. I mean, I've already prescribed more for you than I would for my average patient. So, but still she was asking for more. I wasn't giving her any more. And at one of our follow-ups, like we always do, we check the PMP to see if they're getting controls from anybody else. She had a script that was filled from, and when you check the PMP, you can see who prescribed it. And it was from her primary care doctor. So I looked in the electronic record and I could see the visit with her primary care doctor, and the visit said that she told the primary care doctor that she was no longer seeing me and she was having anxiety and she needed this medication. So this is the patient that's coming back to me to say, hey, I'm here for my follow-up. I need to refill up my Klonopin. I'm like, wait, you just got some Xanax. Oh, I did? Yeah, you got some Xanax from Pam Walker. Oh, yeah, she wrote me a script, but I never filled it. Oh, yes, you did. You filled it on December 10th. You got 30, and it was for a 30-day supply. Oh, yeah, but I never took it. So I'm like, you know what? Because of your dishonesty and my inability to trust you, I will not prescribe this drug for you anymore. And I stopped prescribing. And it kind of ruined our therapeutic relationship because she became very angry with me. And our subsequent follow-up visits was very stiff. There was like this elephant in the room that nobody would address until one day I'm like, you know what? Let's talk about what really happened. And we talked about it, and she broke down to me and shared with me that she was very sorry for what she did, and she would like a chance to regain or to rebuild our therapeutic relationship. And I said, okay, we can do this. And we talked about what happened, how inappropriate her behavior was, and she signed a contract with me. And the contract was that she would not get benzos from anybody else, that I would reinstate my prescribing of her benzo. We would only stay on one benzo ever, because she would request one for her anxiety, and then she'll tell me she's having problems with sleep, and no matter how many different sleep drugs I try, nothing is working. So now she wants Ambien, she wants Lunesta, she wants all those controlled drugs for sleep as well. So we had agreed on one controlled drug. She can't get it from anybody else. It went well for at least maybe 3 months until she started saying I can't sleep. And I might remember our contract. I don't remember signing that contract with you. I don't remember signing that contract with you. I'm not agreeing to that. And let's just say it was probably like a month now. She got very, very upset with me because I was not going to restart another benzo because we had agreed, because of your history of mistrust, we're going to only keep it to one benzo, because I had suspected that she was not using it for its correct purpose, and she has since left and said she will find a provider elsewhere. And yes, she was probably selling them. I have one patient who have a strong suspicion that he was selling them and not abusing them himself. So sometimes the use is not solely for the patient, it could be for monetary gain. Yes. So this patient will have withdrawal symptoms when they don't have the medication, and this is why I try to educate my patients who tell me only Klonopin will help with my anxiety, only Klonopin or Ambien or only that would help, because when I don't have it, this is what happens, this is what happens, or this is what happens. And I try to say to them, these are withdrawal symptoms. Your body is craving for this drug. This is why you're having these symptoms. So education is key. So there's a lot of different effects and withdrawals of major substances. There's alcohol. The effects of alcohol, the withdrawal symptoms. Alcohol, you ingest it. Slurred speech, nystagmus, memory impairment, altered judgment, motor skills are decreased. You could even have stupor, coma. The respiratory changes could happen. So a lot could happen from ingesting alcohol. Something as simple as alcohol. When someone abuses alcohol, they could be in withdrawal when they don't have alcohol. It usually peaks anywhere from 24 to 48 hours. They could have delirium tremors, muscular cramps, vomiting, restlessness, insomnia, hallucinations, anxiety. increased heart rate, blood pressure, respirations, and temperature. And I'm pointing out these things because you're probably thinking, oh, he's an alcoholic, he doesn't have alcohol. I'm pointing out these things. So say you find yourself working on the floor and you have someone who comes in who's suicidal and someone who's going through active alcohol withdrawal. Who's your priority right there?
Seizure precaution.
So is it the alcoholic or the patient who's suicidal?
Alcoholic.
The alcoholic by all means. And I say that because you're thinking suicide, he's going to die. But it's as simple as sticking that suicidal person with a one-to-one or in a self-contained room where there's nothing else, with someone watching them and attending to the more urgent matter at the time, someone who is having respiration issues, heart rate issues, seizures. So know too that withdrawals from these substances can be very life-threatening. The benzos, the barbiturates, those sedatives can cause drowsiness, agitation, slurred speech, uncoordinated movement, disorientation, nausea, vomiting, respiratory depression, which is a big one. And this is why I will say to the patient, no, I will not continue to prescribe Klonopin for you while you're getting oxycodone for pain management. Why? Because of your risk of respiratory depression. And someone's gonna, Lord forbid, something happens and they're gonna look back and say, didn't these prescribers check the PMP to realize that the patients, when you combine these drugs, what their level of respiratory depression could be? And patients will get very upset with you when you try to rationalize and reason through these things with them, but safe practice is important. You have to educate them when they're taking these drugs, what the potential side effects are. Cannabis, which is what everybody smokes, and I say everybody because a large majority of patients will tell you, I smoke marijuana every day, all day. Some of them will tell you. It can cause an increased appetite, dry mouth, tachycardia, paranoia, delusions, hallucinations. And this is why, especially my young adults, when they come to me with those brief psychotic breaks, they're coming out of the hospital after their first psychotic break, and I'm like, lay off the weed. They're like, huh? Yes. Marijuana use can cause hallucinations, delusions. If you have any kind of mental illness laying dormant anywhere down there, start smoking weed, shoot right up to the top. So stay off the weed, guys. Withdrawal could be irritability, aggression, anxiety, insomnia, lack of appetite, restlessness, depressed mood. And you have to educate these patients about not having these symptoms. Say you have a patient who comes to the hospital who was probably, say you're working in a prison and they're incarcerated and now they don't have access to marijuana. They're irritable, they're aggressive, anxious, can't sleep. You have to assess their substance use and appropriately determine whether or not they're going through withdrawal to see how we can treat these symptoms. Cocaine use, also very common, which is, I didn't learn until I got into mental health work, that these drug uses are a lot more common than you would think. Like, I mean, you hear about them, you learn about saying no to drugs until you realize that it becomes commonplace in society and that a large majority of people are using these substances. I've had patients come in who are actively using cocaine. Since I've been home working through COVID, I had, how many patients? Maybe 6 patients die. I had 6 patients die, and out of those 6 patients, 5 of them were drug use. I remember one guy that died, every time he come in, yeah, I use a little coke here and there, and I'm like, it's not safe. How about we look about into rehab? Oh, no, it's not a problem for me. It's just a little, and it's a little until it becomes too much. I have one patient that had no inclination that he was using drugs. And sure enough, since the pandemic, he went to bed. After using, him and his girlfriend are both my patients, he never woke up. I got a call from the medical examiner. He had other substances in his body that I wasn't prescribing. And I wasn't prescribing a benzo, and he definitely had opiates and stuff in his body. So this pandemic, or this epidemic, opioid epidemic, is real, guys. on top of what's going on. So just imagine those patients that are shut in, not able to come out, not able to do what they usually do. What's going to happen? They're going to have increased drug use. That's how they're coping. That's how they cope with stressors in their lives. So even though this short period I've been home, look how many patients I've had die. So we have to be even more vigilant at this time because there's an increased world stressor, not just for them, but in general. Withdrawal, effects of cocaine use, depression, fatigue, craving, or hypersomnia. You could start having unpleasant dreams, psychomotor retardation, agitation, suicidal ideations. Then we have amphetamine use. It can cause impaired judgment, agitation, hypervigilance, irritability, tachycardia. And if you listen to some of these side effects, don't they kind of sound like some of those side effects, some of those symptoms we went through when we spoke about the different mental illnesses? A patient comes in, they're agitated, they're hypervigilant, they're irritable. Doesn't it probably sound like a patient who is manic? So this is why you want to make sure that whatever is presenting is not caused by a substance. And this is why at the end of all of those different diagnoses, there was this disclaimer, not caused by a substance or any medical condition. Amphetamines, withdrawal symptoms or cravings, depression, fatigue, pretty similar to what you see in cocaine. Then we have nicotine. And nicotine is a question I ask all my patients as well. Are you smoking? It can cause hypertension, stroke, respiratory disease, emphysema, COPD. It irritates the mucosa. They need a cigarette. They could start having cravings, feeling nervous, feeling restless. So you want to make sure what's presenting is in fact a mental illness and not caused by a substance, because then it will be treated differently. We have some patients who are using opioids, which is pretty common: heroin, morphine, hydrocodone. They could have slurred speech, impaired memory, judgment, changes in their pupil, as we mentioned, decreased respirations, even death. So from use, they can have decreased respirations. Imagine using drugs along with being prescribed benzo or some other drug that further causes respiratory depression, and sometimes this is how these patients die. Antidote for use is Narcan. I have one patient who's taken an opiate painkiller from her primary care, and when I assumed care for her, I was very adamant that I would not prescribe. I think she's taking Clonopin. It was a benzo, but it's a minute dose, like 0.25 milligram once a day. And besides my best judgment, I went ahead because she was on low doses of both, and she would not agree to not allow me to taper. I spoke to the pharmacist, reached out to the PCP, and everybody was saying it was safe. Everybody but me says it's safe. So you know what? I make sure I document in my notes, advise patient against using both drugs together, offered Narcan, offered to prescribe Narcan. They said, oh, we don't want Narcan, we don't need Narcan. She's doing just fine, but to make sure you document. Again, if you didn't document, it didn't happen. These patients can start having withdrawal symptoms 7 to 10 days. It could be sweating, runny nose, irritability, diarrhea, insomnia. So lots and lots of different side effects you can see from an opioid withdrawal use. Vomiting, nausea. You probably think it's some primary care issue. Turns out it's not. It's because the patient is in withdrawal. So again, very important that we assess these substances and look at the possibility of the patient being either under the influence or going through withdrawals from these substances. There are also inhalants and hallucinogenics, substances that they could ingest. So what is addiction? Addiction is related to psychosocial behaviors. It could be chemical. It could be a process addiction such as gambling, sexual behavior, shopping, internet use. Intoxication refers to significant behavioral and psychological changes after ingesting a substance. It could be polysubstance use. Does anyone know what that is? Polysubstance use.
Multiple substances.
Yes.
Yeah.
So not because they use crack cocaine doesn't mean they don't smoke heroin or abuse alcohol and smoke marijuana. Sometimes, very often, it is more than one substance. It could be a dual diagnosis, which means it's comorbid, which is substance use along with a mental illness. Comorbid diagnoses are very often associated with the person with an antisocial personality disorder, bipolar disorder, or schizophrenia. As I was given my little story about my girlfriend who I used to work with, who had a drug problem, let's just say she shared with me that she was in treatment and then she was getting the help that she needed. It must have been like 2 weeks later she was fired for just irrational behavior. I'm like, I wasn't at work when she got fired, and since she got fired, it's been a couple of years now. But after it happened, we tried reaching out to her, calling her phone. She never answered any of us, so we never got her side of what happened. But judging from what I heard, I'm assuming that she was probably using while at work, because there's no other way she could have made such irrational decisions. There's a table of the consequences of the blood alcohol level, like different things you'll see at different levels. Please take some time to go through that. There's different screening tools. There's the CAGE questionnaire. Like, have you ever felt that you ought to cut down on your drinking? When I worked in corrections, this is one we did for all our intakes. Do you have people felt annoyed? Have you been annoyed or?
I didn't find people on Apple Music.
I'll turn that on. Like, have people annoyed you by criticizing your drinking? Have you ever felt guilty about your drinking? Do you think you ever need to cut down? Do you need an eye opener in the morning? So sometimes I'm talking to a patient who tells me, yeah, I drink. Like, I had one new intake last week, and she's telling me she's having so many life stressors. And I said, how do you cope? She goes, well, alcohol is my coping skill. Okay, it's a negative one, but that's how she copes. So without even her knowing, I'm doing the CAGE questionnaire. Have you ever felt like you ought to cut down on your drinking? Do you feel annoyed because people criticize you about your drinking? Do you ever feel guilty about drinking? So this is just like in conversation, I'm incorporating this CAGE questionnaire to determine for alcohol use. There's also a drug abuse screening test. There's an alcohol abuse disorder test to audit, or there's the online screening. It's called CHUG. Wherever you work, there'll be different screening tests that are used, so just make sure you're familiar with what they are and have them handy so you can use them as you need. If you have a clipboard, make sure you're keeping like a depression scale, suicide scale, alcohol assessment scale, because you always have these things handy when you need them. Assessment. History is very important. You're going to look at the type of substance, the pattern of use, the amount of abuse, age of onset, how it impacts the person's social life and relationships, changes in their work performance, periods of abstinence, withdrawal manifestations. Look at their physical symptoms as well. Nursing diagnosis will cover ineffective coping, like that patient that told me, I have a lot of stressors in my life, so I start drinking. And then she said to me, she's like, well, the other provider, name was Naomi, I'm pretty new at this place, it's my part-time, and she goes, well, Naomi knows my story, and Naomi would always prescribe a benzo when I got like this, because it's the only thing that would calm me down. And I said to her, I am sorry, but I feel very uncomfortable prescribing a benzo for you in light of your current alcohol use. And it's not safe practice. So you have to be able to, be matter of fact, and speak to the patients about their safety as well. Nursing diagnosis could center around confusion, the patient's risk for injury, their impaired memory, their nutritional imbalance. If they're using drugs, chances are they're not eating. This patient tells me, oh, I'm not eating. I'm like, how come you're not eating? How many meals? Well, I don't have many meals. Why? Because by the time I drink, I'm not hungry. So that's kind of giving me a better picture of how much she's drinking, because she's trying to tell me she's drinking 1 to 2 cups a day. Of what? Is it beer? Is it wine? Is it hard liquor? It's 1 to 2 cups of hard liquor.
How big is the cup?
That was my next question. Are we talking about an 8-ounce, 32-ounce, 64 ounces? She goes, the average size cup, but she's still not telling me how many ounces. And she appeared, I mean, she's talking to me and she's all the way up in the camera and she's kind of wide-eyed. I'm like, She looks like she's under the influence as we speak. So these are questions you should ask, like, try to take it out of them, dig it out of them, because you will never know otherwise. Of course, safety is priority. You want to make sure you're looking at the patient's physiological functions, so don't lose sight of what is presenting. Yes, they smoke some weed or use some crack cocaine or whatever the substance is. Make sure you're paying attention to their physiological needs. Observe, assess for withdrawal. And in all of this, therapeutic communication is key. You're trying to establish a therapeutic rapport to encourage the patient to open up to you so you can best meet their needs. Don't let them feel like they can tell you, yes, that, yeah, I just smoked some crack, because you appear judgmental or you're talking down to them. You want to make sure you're there for them, that you're present. Again, try to make sure their needs are met with diet and activities of daily living. Monitor for concurrent illnesses. Okay, so they came in under the influence of crack cocaine. Are they having hallucinations? Is it just because of the crack cocaine? Or are they in withdrawal? Do they have schizophrenia? So you want to make sure you're covering all your bases as well. Look at their any antipsychotics. That could tell you there is more than just drug use going on here. So you just want to make sure you're looking at holistic here, not just the small aspect that you're seeing in front of you. You want to provide education to the patient, the family, as well as the friends regarding substance use, abuse, dependence, tolerance. So you want to point them in the direction of AA, NA, recovery programs, outpatient recovery programs, inpatient recovery programs, all the different things that are there to meet their needs. So different treatment. Therapy, always with substance use. It could be group, family, individual, behavioral, some kind of therapy, because you're trying to look at the behaviors and trying to look at the thought processes and trying to change the behaviors. What do you feel when you pick up a bottle? Like, how does it make you feel when you use drugs? Or what feelings do you usually have before you start using drugs? So it's going to take a huge effort on everybody's part. Like this patient, for instance, she was taking naltrexone, which is the provider before me had prescribed naltrexone for her drinking. And she had only taken it for 3 days, because I did reach out to the previous provider, because it turns out she was a classmate of mine. So I reached out to her. I said, this is what the patient is telling me. And she was taking naltrexone. She goes, yes, whenever I prescribe aversion medications like anti-abuse, Camphor, naltrexone, whenever I prescribe those, she only takes them for a day or two. So that tells you the patient is not vested. She's not ready for that level of change, because she's not investing in taking the steps to help her. I asked her, do you think you need help? She knows she's not open to any rehab, any form of care. And for her to get the help that she needs, she needs the buy-in. We need to get her to buy into the necessity of engaging in this kind of behavior. Change. You want to teach harm reduction, teach them safe things about drinking, smoking, using drugs. As I mentioned, be objective, be professional, be aware of your own background and your own experiences in order to be therapeutic. Were you a child in a house where your father was an alcoholic and you saw how it ruined your mother, ruined your family? Does that affect how you're going to address or engage with this patient? And this is where those things where we talk about transference, like this is where it can occur. This is why you want to make sure you're looking at your own biases, your own self as you enter into these relationships with patients. They could need inpatient care, they could need outpatient care, partial hospitalizations, halfway houses. I have so many patients that are living in halfway houses, recovery houses, all these little programs that are out there to help them improve themselves. And I can't ever remember in this class taking the entire 3 hours, but then I realized it's because we don't have Wednesday night. So it's all crammed into tonight. So we have like 10 minutes left, and what I will do for the next 10 minutes, I historically would have done this at the end of the last class, but I thought about it and I'm going to be more insightful and give it to you guys tonight, so at least you'll have a class after to come back and ask those questions you're not so sure about, okay? So as you prepare for your exam, we've covered a huge amount of stuff, and there's more to be covered, and it's unfair for me to say to you, read everything. I'm also not saying to you whatever I don't say tonight is not of importance, because in fact it is. So not because it's not on the test means it's not something you should learn. So it is my hope that you would have read through all this information and be familiar with this stuff and have some insight into working with patients with mental health issues. So as we go through this list, you want to make sure you're looking at schizophrenia and the different terms surrounding schizophrenia. Like, what are some of the terms we spoke about? There was some like confabulation, ideas of reference, different delusions they could have. We spoke about lithium, and there were some specifications surrounding lithium. If you remember correctly, we spoke about lithium, its toxicities, the symptoms, the causes, the therapeutic levels. We looked at OCD. We also spoke about the emotion that propelled OCD. And what did we say that was? Anxiety, thank you. What are some expected findings in a patient with OCD? What are some signs and symptoms of OCD? If a patient is having a manic bipolar episode, what are some nursing interventions? What are some things you'd probably see? I mentioned a patient is suicidal, and I also mentioned that one thing I make sure I have from this patient at the end of our conversation, if it is that they're not going off to an acute care setting, what was something I said I make sure I try to have with this patient before I wrap things up? Does anyone remember? I have them contract for. Something to think about. We looked at different substances, and we looked at withdrawal symptoms as well. We want to look at alcohol. We talk about schizophrenia again and the different types of delusions. There are lots and lots of different types of delusions. We spoke about disorders that present with children and adolescents. We spoke about different personality disorders. I also mentioned that there's one personality disorder that is more prone to like self-harm. You see more comorbid with like eating disorders. We looked at the paranoid personality disorder. There are different key things that play into someone who has a paranoid personality disorder. We spoke about drugs that we can see patients on that are in recovery. We've spoken about patients' rights, cultural considerations that we should look at. We look at SSRIs and antipsychotics. We look at those drug classes. What are some of the adverse effects of using those drugs? We looked at non-pharmacological treatments such as ECT. And we will be looking at and I'll save the rest of this list until we cover those Alzheimer's and dementia. We spoke about PTSD. What are some hallmark symptoms of PTSD? We also discussed prioritizing care for our patients as you look at their hierarchy of needs, like what are some things you need to consider in terms of deciding which patient should be higher on the priority list. We spoke about respecting the patient's rights, the need for informed consent, the need to educate patients about what is happening or what could happen. We spoke about suicide. Any questions for me right now? Okay, and that brings us to the end of tonight's class. I will see you next Monday. And next Monday's material, I'm pretty sure it's a little shorter, and we can discuss some of those things I mentioned tonight for the list of things you should look at, okay? Enjoy the rest of your week.
Thank you, you too.
Welcome, thank you.
Have a good week.
Thank you, same guys.